First, I want to give you a little insight about me. I started out in child development, undergraduate in psychology at Stanford, got involved with the child development laboratory there in Owens House, and also with the experimental nursery school, Elizabeth Bing experimental nursery school with one-way mirror observation of children and all of this. And people like Skinner and Fantz and T.G.R. Bauer, and of course the great Jean Piaget, stimulated me to really be excited about child development, except I realized it all depends on the brain and how it develops. So then I decided to go to medical school, UC San Diego, did pediatrics at Johns Hopkins, went back to Stanford for neurology, and then did a year of fellowship in developmental neurophysiology at Mass General in Boston. I have been involved in understanding the nervous system of children for about 45 years. I still don't understand it, but at least I have a lot of background. Now, with that, what I want you to do is to understand that I like to just make things simple. So we have 4 areas of development. The last 2 I kind of fuse into one. So the first is in gross motor. Now, obviously, we're talking about things like sitting, standing, walking, running, jumping. But you have to understand that there are 2 phases to this. There's what we call the central development, peripheral development. The central development, obviously, there are specific regions of the brain that are necessary for the development of sitting, standing, walking. And those could be damaged. Peripheral are also critically important because you're looking at things like, obviously, nerves and muscles. These can have a dramatic effect, and even things like regional spinal cord defects can have major impacts on gross motor development. That's why it's very critically important to think about it from those perspectives. Fine motor is then the next big category, and that's the thing like using the hands for initially picking up and then hand-to-hand transfer, and then things such as midline play and learning to button, zip, use pencil, crayon. Obviously, this implies central as well as peripheral implications as well, and you have to think about these as major elements in development. The third and fourth I fuse together because I call it the social verbal. I actually do not like the term cognitive because I'm not sure anybody understands what that really means. Social verbal is the best way of kind of thinking about this. Now, obviously, some of the very first things is mother versus others. That social developmental milestone. Stranger anxieties, but also the fascinating thing of watching the anxiety curiosity play off as the child is clinging to the mother, but really fascinated about that little toy over there, and that absolutely fascinating phase of the anxiety curiosity. Extraordinarily important to watch that.
Good morning. I was asked to do a presentation on billing for developmental screening. The presentations that I've been listening to that are preceding me really gave a big overview as to what we're actually addressing today. Is there's a big disconnect between how do you implement the process of the developmental screening that you're doing, and actually then getting actually billed and being reversed for at the end. So there are 2 reasons that the pediatricians and family care physicians are in a unique position to promote developmental health and that is you have regular contact with the children before they go to kindergarten, and that's the best opportunity to actually identify developmental problems as well as any other health problems that are unique and to that child. There are actually CPT codes for the developmental screening. The CPT code 96110 is actually a limited, that is, it's a developmental screening test, early language milestone screening with interpretation and report. So if you do this type of service, there has to be a report and there must be an interpretation in the chart itself what has been done with that report. So the CPT 96111 is actually developmental testing, and it's actually extended. It includes assessment of motor, language, social, adaptive, and Dr. Goldie doesn't like cognitive, so we could say social, whatever he said, functioning by standards developmental instruments. And that also has with interpretation report. The two CPT codes in itself means that you need to have an interpretation and a report actually in the chart itself.
I'm a general pediatrician. I don't have any specific training in developmental pediatrics, but after 30 years in general peds private practice and the past 4 years with the county system, I've learned a lot. And the other pediatrician at Sierra Vista and I took responsibility for developing a system within the clinic to implement developmental screening, and I'll share our experience with you. Sierra Vista is one of the county clinics in which we have 2 pediatricians working as one full-time equivalent, a physician's assistant, several family practitioners, 2 LVNs, and a bunch of MAs. Our initial approach was to first, did I go back? Yeah. The first thing we did in terms of implementing the developmental screening was to just informally approach some of our colleagues and get a feel for how they felt about it and get their buy-in to participate. We started with, our patients also are a very low educational level, which was a factor in how we did it. So we first approached some of the other providers and found that some of them thought they were already doing developmental screening. Of course, they were doing surveillance, and we pointed out to them that we could detect more developmental problems earlier if we did more formal screening. Some of them were just slightly resistant at the beginning, not very, but you know, they felt that they were identifying the patients. And I think perhaps many of them were. The statistics show a lot of them being missed. So we presented to them the fact that parents are very sensitive to their child's behavior and needs, but parents develop vary a lot in their abilities to observe, to communicate. So as previous speakers mentioned, the surveillance is performed by most family practitioners and pediatricians at every visit, but we need to do more objective screening in addition.